guys, welcome back. So today I want to do paper 2 with you guys. So we start with respiratory examination. It's the examination of the posterior chest. So I have done this in many other videos. So I think I've done this in paper 3 and paper 9. So I will just link the videos for those on the description box, so I'm not repeating myself too much. And then the next one is the examination of the superficial lymph nodes. So we need to examine the lymph nodes of the head and the neck for 3 points. Okay, so let's start with that. So we have 10 lymph nodes in the head and neck region. So we have the preauricular, located just in front of the tragus of both ears. So these are the preauricular. We have the posterior auricular, located superficial to the mastoid process. We have the occipital, located at the base of the skull. We have the tonsillar, located kind of at the edge, just below the edge of the mandible. And then we have the submandibular, located between the edge of the mandible and the tip of the mandible. All right, and we have the submental, located behind the tip of the mandible. And then we have the cervical lymph nodes. They are kind of like in a Z shape here in the sternocleidomastoid. So we have the superficial cervical lymph nodes, and then the deep cervical lymph nodes, and then the posterior cervical lymph nodes. Also, we have them on both sides, so make sure you palpate both sides. And then we have the supraclavicular lymph nodes just above the clavicles. So just to recap, there's 10: the preauricular, postauricular, occipital, tonsillar, submandibular, submental, the superficial cervical, deep cervical, posterior cervical, and the supraclavicular. So when we're feeling for this, we're feeling for things like the size, the shape, the consistency of the nodes, any nodules, or any tenderness or enlargement. If, for instance, the supraclavicular nodes are enlarged, especially the left side, then you need to suspect for metastases from any like thoracic or abdominal malignancies. Okay, then moving on to the chest lymph nodes, it says here we need to palpate for the central, the lateral, and infraclavicular. Okay, so for chest lymph nodes, we have the axillary nodes. So the axillary nodes, okay, I don't know how I'm going to show you, but okay, let's start with the central lymph nodes. So the central lymph nodes are located at the base of the axilla, really deep in that axillary fossa. I don't know if it's axillary fossa, but really deep in that that axillary region in the middle. That's why it's called central. And then the lateral lymph nodes are located at the upper portion of the humerus. And then we have the scapular lymph nodes, located at the lateral border of the scapula, deep into the posterior axillary fold. And then we have the pectoral lymph nodes, which are located at the border of the pectoralis major, deep into that anterior axillary fold. Okay, so again to recap: central, lateral, pectoral, and scapular. And then we also have 2 additional ones for chest. So we have again the supraclavicular, and then we have the infraclavicular just underneath the clavicles. And then we move on to the inguinal lymph nodes. So superficial inguinal lymph nodes, we have the horizontal group and the vertical group. So the horizontal group, they lie in a chain just below the inguinal ligament. And then the vertical group, they lie in a vertical chain in the inner thigh, located just at the like the upper portion of the great saphenous vein. Okay, and then okay, so that's it for the lymph nodes. And then we move on to the spleen. So we need to palpate and percuss the spleen. So palpation is for 2.5 points. So the thing with the spleen is that It's usually non-palpable because it's tucked underneath the rib cage on the left side. It's only really palpable if it's inflamed because it gets bigger. So when it's inflamed, it becomes enlarged, so it moves inferiorly and anteriorly. And so it's like the splenic tip is only palpable in like 5% of the normal population. So it is possible to be able to palpate the spleen, but not very often unless there's something wrong, unless it's inflamed and enlarged. So the way that you palpate for the spleen is you place your left hand at the back of the right upper quadrant, just at the back of the rib cage, and then you press up on that, and then using the other hand you palpate the costal margin. You press down into the spleen and ask the patient to inhale and feel the splenic edge as the patient takes in a big breath. So when they inhale, this fills up the lung, pushes the diaphragm down, and pushes the spleen down a little bit. So you may be able to feel the edge of the spleen brush against your fingertips. So you feel for things like obviously enlargement, the texture, any nodules, and any tenderness. Okay, so that's it for palpation. And for percussion, for 2.5 points, it says percussion with specification of the Traube's space. Okay, so for percussion of the spleen, firstly we need to basically percuss the anterior aspect of the like anterior chest. So we locate the sixth rib and we percuss from the sixth rib laterally towards the anterior axillary line, which runs from there to there, and then from the anterior axillary line we go downwards to the costal, the left like costal margin. Okay, so this space here is called the Traube space, right? So again, sixth rib, you percuss laterally to the anterior axillary line, and then downwards to the left costal margin, and this is a Traube space. So normally it should be tympanitic. So if it's predominant tympanitic, then this makes the possibility of a splenomegaly very unlikely. But if there's dullness in the Traube space, then this may indicate splenomegaly. But it's not complete science, because the dullness in the Traube space can also be due to the fact that the stomach is filled with like fluid or with solid like food stuff, because the stomach is kind of located around the same area. So but anyway, it gives you a good like idea if there is splenomegaly anyway. Also, another thing you could do for percussion is you follow the anterior axillary line down to the very last intercostal space. The anterior axillary line down to the very last intercostal space, and you percuss that area, and then ask the patient to take in a deep breath, and you look for a change in the percussion notes. So as I said, it should be tympanitic, and upon inspiration, if it changes to dullness, then again this may suggest splenomegaly, but again it's not complete, it's not completely accurate, but again it gives you a good idea if the spleen is enlarged or not. And then moving on to the nervous system, we have cranial nerve 11 and cranial nerve 12 examination. So cranial nerve 11 examination for 2 points. So the cranial nerve 11 is the spinal accessory nerve, which innervates the sternocleidomastoid and the trapezius muscles. So to test for this, we go behind the patient and we ask them to shrug both shoulders. So shrugging activates the traps, the trapezius. So we ask the patient to shrug against our hands that are like applying resistance. So we're applying like a downward force as the patient tries to shrug up, and we feel for the contraction of the trapezius. We look for things like symmetry in contraction and the actual strength or force of contraction. And then for the sternocleidomastoid, we ask the patient to turn their head against our hand that's applying resistance, and we look for the contraction of the sternocleidomastoid, and we feel for the strength of contraction. And we just repeat that with the other side. And then for cranial nerve 12, which is the hypoglossal nerve. So the hypoglossal nerve innervates the tongue. So it's responsible for the motor functions of the tongue, which affects articulation of the words, of spoken words. So we just observe we observe the patient as the patient speaks, and we note their articulation. If they have poor articulation, also known as dysarthria, then they may have damage in the hypoglossal nerve. The next thing is we just observe the tongue inside the roof of the mouth, and we look for things like atrophy, any abnormal fasciculations, any like abnormal movements, and things like that. And then we ask the patient to stick their tongue out and move it side to side, or just move the tongue. And we look for things like, again, symmetry, as when they stick their tongue out. It shouldn't point towards one side. So if it's asymmetrical, if it points towards one side, this is indicative of hypoglossal nerve lesion, and the tongue would point towards the side of the lesion. And again, we look for things like, as I said, symmetry, atrophy, and any abnormal fasciculations.